very much. Thank you to the whole organizing committee, and thanks for Thomas for extending the invitation to give this talk. Obviously, compared to the previous speakers, we're dealing with a very, very different level of evidence here. RCTs in penile cancer are completely lacking, and all the data that I'll show you are based almost exclusively on retrospective series. I'd like to ask the Swiss organizers, is penile cancer care centralized in Swiss? It's not. So if you could please, could you raise hands if you treat more than 5 new penile cancer cases a year? 1 or 2? So this is a disease that's very rarely encountered by general urologists, and therefore also, unfortunately, very often indeed managed too aggressively, or when we're talking about lymph node management, often not aggressive enough. So penile cancer is, as you know, very often squamous cell carcinoma. It's very rare. It's 0.1 to 1 in 100,000 in the Western world. There's certain parts of the world where it's much more common, and these are often poorer areas with higher HPV infection rates, and HPV also is therefore a risk factor for developing penile cancer. Prognosis is not determined by the local staging, but more by the lymph node extent, and there's several different subtypes with each their different prognosis compared to the others. TNM staging has recently changed. T3 cancers are now cancers that invade the corpus cavernosum, and T2 cancers are now cancers that invade the corpus spongiosum. So urethral invasion is not an independent factor anymore, and urethral invasion does not necessarily designate a tumor as T3, because we had the problem that lesions at the end of the urethra, so at perimeatal or meatal lesions, were often classified as T3, but could be treated and had the same prognosis as the T1 or T2 lesions. So the EAU guidelines state that the aims of treatment of the primary tumor in penile cancer are complete tumor removal with as much organ preservation as possible, so with as much preservation of the penis as possible, but without compromising oncological control. And during this presentation, I'll try to illustrate how this is done and what the criteria are here. So eligible are CIS, T1, T2, and also to a minor extent T3 lesions that only involve the tips of the corpora cavernosa. So the principles of penile preserving surgery is first, up to 80% of the lesions are encountered on the glans or the prepuce. So 4 in 5 lesions of penile cancer are confined to the very distal end of the penis, which also means that you only have to resect the very distal end of the penis. Furthermore, margins can be minimal. Local recurrence is more prevalent when you do organ-sparing surgery, but it appears to not influence a cancer-specific survival. And patients must, of course, be very compliant to strict follow-up, because if you're going to respect more minimal margins, they have a higher risk of local recurrence, and you want to detect these recurrences early to ensure that they indeed do not impact your survival rates. So classical teaching stated that we should respect margins of more than 2 centimeters, but then in the 1990s, Hoffman and colleagues, they showed in a retrospective series, as all these data will be, that less than 10 millimeters did not increase the chance for local recurrence. And Agarwal showed in a histopathological study that the lesion that you see when you look at it microscopically, most of these lesions do not have extent of tumor cells more than 5 millimeters beyond the macroscopic lesion. Then Minhas and colleagues and Philippou, all from UCLH in London, showed first that less than 10 millimeters does not result in a higher rate of local recurrence, then that less than 5 millimeters does not result in a higher local recurrence rate. And Philippou and colleagues also from UCLH also showed that if you do frozen sections intraoperative and confirm negative margins, however small they might be, that recurrences are very likely to occur. Then there's a very recent publication from St. George's in London, who shows that even a clear margin of less than 1 millimeter compared to more than 1 millimeter predicts a higher rate of local recurrence. So they state now that very, very few millimeters are needed. And what they saw, that if a patient had local recurrence, often that was not determined by margin status, but rather by LVI or cavernosal spread. So the group from St. George's actually state that the guys that do experience a local recurrence, probably this is an embolic spread rather than a direct continuous spread in the skin of the penis. Local recurrence does not impact disease-specific survival. The group from Amsterdam showed a very high disease-specific survival of 92% in the group of patients of which 109 experienced local recurrence. Again, the London group, similar disease-specific survival. Then the group of Amsterdam did a multivariate analysis to show that patients who did experience a local recurrence did not have an elevated disease-specific survival. And also our group, when I was working at UCLH, showed in the group of glansectomy only that if patients experienced a local recurrence, this did indeed not impact their survival if managed correctly. You might, however, ask the question whether these were not overfitted multivariate analyses. But hints are that local recurrence, if managed correctly and if detected early, will not impact the survival of your patient. So this also means that you can be a little bit more restrictive in surgery as long as you follow them up very carefully. Follow-up at the moment is specified by the EAU guidelines that you should see your patients in the first year every 3 months, that they should do regular self-examination, then semi-annual years 3 to 5 and yearly from 10 years on. I do like to make note that the lymph node status, of course, is much more important for how you determine your follow-up in your penile cancer patient. Workup is done with clinical exam, so most tumors can be easily, the T-stage can be easily determined with a clinical examination. We only do biopsies in doubt, so if it's not a very typical lesion or if we doubt that there's a different, for example, dermatological inflammatory diagnosis may be in place. Ureteroscopy is performed in lesions that abut the meatus, and MRI can aid staging, but we in Leuven currently only perform them in cases of doubt. So the vast majority of penile cancer tumors you can easily stage with a clinical examination, and especially in experienced hands, it is quite readily doable to examine whether or not corpora cavernosa are involved or not. If you are in doubt, this is a very clear cavernosal invasion. This is a little bit more difficult to see, but you can see that the tunica is not very well lined here, and here there's a tumor that is abutting the tunica, but it's not invading it. So if you are in doubt, MRI is a good examination, but then recommendation is that you do a prostaglandin injection first to give the patient an erection so the corpora cavernosa and the tunica albuginea lining the corpora cavernosa are more readily identified and easier to be discerned from the tumor. Techniques are varying, so a lot of different techniques are used in organ-sparing surgery. First, of course, circumcision and or wide local excision for lesions on the prepuce or on the base of the glans or the coronal rim, which is a very easy technique which every urologist obviously can do. Here you can see example of tumors here on the base of the glans, even extending up to close to the meatus, which can easily be covered by a preputial skin flap. Other techniques include hemi-glansectomy, in which you either can remove the lower half of the skin and spongy tissue of the glans, or a longitudinal half of the skin of the glans for larger tumors who are restricted to the glans and the corona. Full glansectomy can be done for larger T2 lesions on the glans that are not amenable to wide local excision. In this technique, the whole glans is lifted off the tips of the corpora cavernosa, and I'll show a video of this later, until the urethra remains. The urethra is then divided. Section margins are taken at the tips of the corpora cavernosa and of the urethra, and then a reconstruction can be done as described for the first time by Brocca of the glans with a split thickness skin graft, and I'll detail that a little bit more in detail in the video that I'll show after this. Very similar is glans resurfacing. Glans resurfacing is suitable for patients with carcinoma in situ that is too extensive, or that you deem too extensive to treat with local excision, or to treat with topical therapies such as imiquimod or 5-FU. In these cases, you can remove the skin layer of the glans and cover the spongy tissue of the glans, again with a split thickness graft or with another graft of your liking or what you're used to working with. Large surface CIS, there's 20% invasive component in the extensive CIS, so those patients are, in my opinion, more amenable to surgical treatment than to topical treatment to uncover whether or not there is an invasive component present. Then T3 lesions, so T3 lesions that are involving in the distal tips of the corpus cavernosum, even those are still amenable to organ-sparing surgery. Of course, we used to do always partial penectomy for these lesions. We now know that the margins can be very minimal, and we also have reconstructive techniques to, even when you have to resect the tips of the corpora cavernosa, you can reconstruct them with a urethral centralization to make it look like a normal glans, and then cover them with a split thickness skin graft, suture the skin against a neocorona, and the penis might have an appearance that is very similar to a normal penis again, even after a distal partial penectomy. This is a technique that was developed by Peter Malone in London and also published recently in a German journal. If you could start the video, please, in the back. So Thomas invited me, I think, after seeing a video I presented at the AUA. So I'll show you an excerpt of this. So this is organ-sparing surgery as we did it, or as we do it. This is a case of glansectomy and a case of glans resurfacing. Here you can see our hospital in Leuven, very small city, but we have quite a decent hospital has been built there. This is a case that had been operated in Tenerife because of suspicion for incarcerated inguinal hernia, but it was a lymph node metastatic penile cancer. However, the lesion on the glans was amenable to approach in a penile conserving manner. In Belgium, the large majority of men are not circumcised, so hygienic circumcision is not something that's routine or common practice in Belgium. So we start by excising or by incising the outer prepuce. We then dissect directly onto the buccal fascia, and in lesions in which you can feel that they are not close to the tips of the corpora cavernosa, you can easily find the dissection plane over the buccal fascia without touching or without dividing the neurovascular bundle of the penis. It's a relatively bloodless plane, and we also do this surgery without a tourniquet or without a garrot. So we dissect onto the tips of the corpora cavernosa where the neurovascular bundles get very thin and you do not really encounter big arterial vessels or nerves anymore, and you can then divide the urethra to lift off the glans. This is a different technique. This is this we filmed in London. This is Asif Munir doing this surgery, in which the neurovascular bundle is divided, and then you get to the plane which is directly onto the tunica albuginea. And this technique we choose if on MRI the lesion is very close to the corporal tips, or we suspect we might have to resect the corporal tips. In this way, you're dissecting after division of the neurovascular bundle, which you see here. You're dissecting onto the tunica albuginea, and you can readily identify whether or not a tumor, when you reach the tips of the corpora cavernosa, whether or not a tumor invades these tips, so you can make a decision perioperatively on whether you want or whether you don't want to resect the tips of the corpora cavernosa. And again, under the neurovascular bundle, onto the tunica albuginea, there's a nice bloodless plane. When the glans has been lifted off, we splay the urethra over the tips of the corpora cavernosa to make a nice wide neomeatus, and we suture the shaft skin against the tunica albuginea or the buccal fascia at the level where we would expect the corona to end up. And this is the final appearance before we are going to apply a graft. So the next case is glans resurfacing. This is a 57-year-old man with biopsy-proven PEIN type 3, covering almost 60% of his glans and a prepuce. So we discussed the options with the patient, and the patient opted for likely the most radical treatment in the form of a glans resurfacing. So what you can see here is that we really superficially incise the skin of the glans. This is done under tourniquet because you will often notice that once you get towards the corona or the coronal rim, this gets a little bit more bloody, so it's easier to do under a tourniquet protection. And then you can see that you lift off, you divide the glans in quadrants, you lift off a very small corner of each quadrant, and then you can easily grasp it within 2 fingertips and reflect it back, so you can see where the shiny white layer, which is the underlayer of the epidermis, is readily visible, and you can, with a cautious meticulous dissection, you can dissect off the skin of the spongy tissue of the underlying glans. And so we do this in quadrants, and after we reach the coronal sulcus, we will complete the circumcision and remove the whole specimen. which we then provide to the pathologist in a marked fashion. So we pin it down so the pathologist really sees which quadrant belongs where. So we complete circumcision here, and then the specimen is removed. Then the tourniquet comes off, and you can see that once the tourniquet is off, the gland starts to ooze. There's no reason to do specific hemostasis to these oozing glands, because we know that once the graft will be applied, this oozing will automatically stop. It's almost always the case, and I don't know what the reason is, but it might be due to factors that encourage hemostasis that are at the undersurface of the skin, of the split thickness skin graft that's going to be applied on top of this wound surface. So again, we create a neocorona at about 2.5 centimeters from the meatus. Then we take a split thickness skin graft that we set to 0.018 of an inch, which is a thickness that I find ideal in that it's not too thin, so it's still easy to work with, and it's not too thick, so imbibition is still possible, and the grafts have a high taking rate. But this is a delicate balance between a graft too thick and too thin, and this is something that you can learn, of course, during fellowship training, but most of all, you'll have to do it a couple of times to appreciate what is the most to your liking. So we apply this graft. The graft has to be applied very, very tight. So we do this with 5-0 monofilament sutures. It has to be very tight, so the contact surface of the graft to the underlying spongy tissue is large, and there's no space for hematoma built up under the graft. To further prevent this, we quilt the graft to the underlying wound surface, and then again you'll see that we also make some minor or small cuts to let the blood that is pooling under the graft to let it out. So there's no hematomas, and the contact surface of the graft is large, and so the graft taking rates are hopefully high. We're a little bit reluctant of doing this technique in patients who are refusing to quit smoking, and in uncontrolled diabetes. Of course, we know that graft taking rates there due to vascular status are not so high, so we always counsel them to quit smoking and or counsel them for other options that have less risk of complications in these cases. Then we finish with a tie overdressing. This is also something I learned from Peter Malone in London. So this is just a surgical scrub sponge, sterile, covered with one layer of paraffin dressing, and just so we suture it round and round, and we suture it onto the graft so the graft doesn't move compared or in relation to the wound bed. So it's always fixed in the same position, which allows for microvasculature to develop and neoangiogenesis to provide adequate vessels and oxygen to the graft to allow taking. We leave it on for 12 days. That's probably a little bit too long, but that's what I'm comfortable with. And we leave the ureteral catheter in for 12 days as well. Then the patients come back. We take off the dressing and the catheter at once. We give them 5 days of antibiotics, which also is probably a little bit too long, but this is the time it takes for neoangiogenesis to happen, and infection is one of the major risk factors for graft loss. So this is what it looks like when we remove the dressing, and this is what it looks like a couple of weeks or months later. You can see the graft taking site there, which is a little bit reddish discoloration, which is under the level of to where swimming trousers would come, and the final appearance of the glands is more or less similar to what you would expect a normal glans to look like. So this is the technique we use in Leuven. What are the outcomes? Outcomes are quite heterogeneous, and this is due to the setup of the retrospective series that have been described. Local recurrence rates are varying between 27, 21 to around the range of 10%, and this is depending on the cases that are included in the series and the techniques that are used in the series. So we recently published an overview article in Current Opinion Urology, which I co-edited together with Philippe Spies, and one of our residents really went through the literature and examined all the series that are published. And what you can see is that recurrence rates are varying according to the number of high-grade included in the series and the technique used. So if there's a lot of series that use a lot of circumcisions, these are probably smaller lesions. If there's a series that employ a high rate of laser surgery, those have higher failure rates, because we observe that laser surgery just has higher failure rates than cold knife excision. And we can also see that single technique series, such as glansectomy only series, often have higher recurrence rate because these tumors just are more aggressive. Otherwise, they would have been managed with more minor mutilating surgery. So there's some risk factors that have been identified for local recurrence. First of all, higher stage, higher grade, relatively logical. Then concomitant cyst also is a risk factor for local recurrence. Is that then a local recurrence, or is that then a new lesion developing in an area of cyst? That's of course the question. And then some others, PNI, LVI, positive margins and very, very low margin rates, but what is protective is performing intraoperative sections. And we've devised a risk score taking into account 4 of these risk factors, and you can see that we can predict the risk of local recurrence according to the risk factors present in the pathology specimen. And our goal of this publication was that we can then tailor follow-up to the patient's needs. But then again, if this patient has positive lymph nodes that were managed, of course, this is going to primarily determine how often these patients are going to come back for follow-up. But at least it's a helpful tool in counseling the patients about the risks and instructing them on self-examination if several risk factors were present in the pathology report. So if we look at overall survivor data, these are population data. You can see that patients managed with organ-sparing surgery do as good as patients managed with classical partial penectomy, and patients with total penectomy do a little bit poorer. So can we draw the conclusion, therefore, that organ-sparing surgery is as good as partial penectomy? Well, probably not, because, of course, there's a selection bias in the fact that the partial penectomy series include patients with higher T stages than the organ-sparing surgery series. Alternatives include Mohs micrographic surgery. This is surgery is often done by dermatologists, in which small sections of the tumor are shaved off and then real-time looked at under the microscope to see whether the margins are clear, and they keep cutting until the margins are clear. This is very time-consuming. You have to have an expert pathologist in the room, and the series showed that the results are not better than conventional surgery. I don't think that many urologists actually employ these techniques. It's mostly done, I think, by dermatologists. Then topical therapy is alternative therapy in cases with CIS only, so biopsy-proven CIS, and their organs. This is of course also organ-sparing therapy. There we have 5-FU, which is chemotherapy, and then we have imiquimod, which is toll-like receptor agonist, which stimulates the immune response against the cells in the carcinoma in situ. So data on these therapies is very limited. There's a couple of series with in total 44 versus 48 patients, and these show that response rates are quite good, but that local skin irritation is a very common side effect, and so you have to counsel your patients very well. If you put them on imiquimod, they will have scalding of the skin, it will be red, it will sometimes become bloody, and it's a very fierce inflammatory reaction, so your patient has to be counseled for that. Important is that you remember that if your patient does not respond adequately to topical therapy, that you'll have to do surgery on him, because chances are high that he has an invasive component. Radiotherapy and brachytherapy also are alternatives to organ-sparing surgery as an organ-sparing approach. It's used very infrequently. In Leuven, before a couple of years, brachytherapy was employed quite a lot. The thing I find difficult in brachytherapy is that these lesions are very difficult to follow up. There's often a lot of fibrosis, a very aberrant aspect of the glans. It's sometimes very difficult to discern clinically between a local recurrence and a sequela of radiotherapy. Local control rates are relatively poor, especially compared to surgery, and the other drawback of using radiotherapy is that your staging may be inadequate. So if you do surgery, you have a correct pathological specimen, you will be able to correctly assess whether this patient is a high-risk patient for lymph node metastases, and therefore you can base your lymph node staging strategy on your pathology report. If you do radiotherapy, you will often only do incisional biopsy or circumcision to prevent complications of the radiotherapy, and this may be inadequate as a biopsy to assess the risk rate or the risk status of the patient and to determine whether or not you should go for a sentinel node or modified inguinal lymph node biopsy. Laser is often used. Has very high local recurrence rates. We know what the penetration depth of the lasers is that we use, but probably ablative therapies are not as ablative as we think they are, and there's probably some residual tumor that we don't see after a laser ablation. Even in CIS, which is limited to the skin only, a recent multi-center study showed a 60% recurrence rate. So I really abstain from laser therapy. I don't really believe that it's adequate therapy for penile cancer. So quality of life, we know that if you use organ-sparing surgery, quality of life is much better than if you use total penectomy, which is, of course, obvious and logical, and also than if you use partial penectomy. Surgery for penile cancer causes distress in a significant number of patients, and the distress is often a little bit less when you can do as much penile conserving as possible. And a recent Chinese study showed that if you can do glans preservation, you should do glans preservation, as the satisfaction is much higher perceived by patients as well as their spouses. Finally, some words on centralized care. I do know that it's not the center topic of the title that I was given. So centralized care is, I think, vital for adequate management of these rare tumors. It has been done in the UK, where the guidelines now state that 25 to 40 new cases per year have to be managed within a team. And that means that there's about one center in 4 to 10 million population. In Holland, Simon Horenblas has done a lot of work on penile cancer, and I don't think that centralization there is government issued, but it's mostly academic driven. So due to the expertise, patients are now, I think, almost exclusively referred to Simon Horenblas's team for management. In Scandinavia, there's 2 centers in Sweden, there's 2 centers in Denmark, and they do weekly national MDTs. And the European Union, this is not centralized care, but it's pooling of expertise. The European Union has now issued the development of rare disease reference networks, the ERNs, European reference networks, in which groups that treat rare diseases are pooled, and we have MDTs every month on penile cancer and other rare urological cancers. And Vijay Sanjar, who works with Noel Clark, is the lead on the rare urogenital cancers in eUrogen, which is the reference network for rare urogenital pathology. I know Swiss is not a part of the European Union, but I read on the website of the Swiss, I don't know the name anymore, but the Swiss Institute for Geseltene Krankheiten, is that correct? For the Swiss Institute for Rare Diseases, that they cannot formally partake in the ERNs, but they do encourage informal collaboration and while working together and discussing patients with the ERNs. So please feel free to, if you have a complicated rare urogenital cancer case or a penile cancer case that you have difficulties managing or that you have questions about, please approach us and we can incorporate you in the MDT and discuss the case with several people throughout Europe together to come to a good solution for your patient. We know that not only the urologist is important in centralized healthcare, it's the whole team, obviously. Histological diagnoses are often changed after centralized pathological review. There's a higher percentage of patients treated with penile preserving surgery in the UK after centralization was instituted. But more importantly, in the UK, they showed that 5-year survival of penile cancer was reduced with 12% after centralization has been implemented. So I think these are very important data, and these are percentages that are very difficult to achieve with any therapy. In Belgium, we do not have, so this is the website, sorry, for eUrogen, so please feel free to visit and have a look if you're interested. In Belgium, we do not have centralized healthcare, but we're working on it in Leuven. We're trying to do research in penile cancer. We're doing a biorepository, so we're collecting all the tissues. We are prospectively collecting data of all our patients. And we are making a case in Belgium that higher volumes probably result in better outcomes. And this year, we have treated over 50 new cases, where in Belgium, 88 per year are diagnosed, more or less. So we're making advancement in Belgium as well to go towards centralization, but I hope we can continue this growth in the next coming years. So to conclude on the talk, organ-sparing surgery should be employed in all cases of penile cancers that are amenable to organ-sparing surgery. Margins can be very low, and recurrence rates are higher than if you do conventional surgery, but these recurrences likely do not impact cancer-specific survival, and patients should be counseled on these aspects and should be compliant to strict follow-up to be amenable to organ-sparing surgery. Thank you very much.